Speaking of rational revolution, Peter McCullough has been at the forefront of the rational discourse during the irrational certitude of the COVID era. You can follow him, as I said, on XP_McCullough, McCulloughMD on X, PeterMcCulloughMD.substack.com, and PeterMcCulloughMD.com. And then we'll have Joel in a little while. But Dr. McCullough, welcome back. It's such a privilege to have you, and thank you for joining us. I'm looking for an update for our viewers, the kinds of things you're seeing in the clinic in terms of the long vax, long COVID, how we've been able to distinguish between long vax and long COVID. And, I don't want to get too deep in the weeds because people don't want to, hear our therapeutic sort of thinking so much as to talk about, how you construct in your mind what long vax is now and the kinds of treatments you're finding effective.
Well, first, let's take the infection. The infection is now very infrequent. We are into the Omicron variant NB 1.8.1, so-called Nimbus, razor blade sore throat. You probably saw that. So some people are reporting a prominent sore throat. It's about 36%
oh my God, run
of
for the hills.
The CDC says it's so rare, they can't be sure on the proportion of strains now on their website. So COVID itself fizzling out. Long COVID persists, but I think it's progressively less frequent because the infection is less frequent. And so now we're really left with, the residual penumbra of problems after the vaccine.
I get long COVID every single time I get COVID. And I will tell you, I've seen two variants coming around Southern California. I got one of them. And the one I got was just rhinorrhea, just a severe runny nose and maybe a little bit of fatigue. And then I'm so familiar with long COVID when I get it. It's a very specific feeling. It's like a hollowness and a fatigue that I recognize it immediately now. And even though the acute infection was nothing, I had this week of post-COVID. I had it. And then the other, what I believe to be NB181 that's coming around here is pretty nasty. And I've been using Paxlovid for it because it gets people pretty sick. And guess what? So far, everybody has a rebound on the other side, and this rebound is extremely characteristic. It's the same rebound I saw from COVID 2 years ago when I used to use Paxlovid, which is a cough. It's just this nasty, nasty cough. It's not fatigue, it's not long COVID, it's just this cough. Weird. But in any event, talk to them about what we think we're doing with the long vax now in terms of clearing the spike and dealing with the coagulation issues.
Well, first off, we've published a paper listed in the National Library of Medicine, PubMed, and it's titled Risk Stratification, for people who've taken the vaccines. Very important paper. I take a careful COVID history, how many documented cases of COVID, and a careful vaccine history, how many different vaccine shots, because they both contribute spike protein. Here's the virus. The ball of the virus is a nucleocapsid. Here's the spike protein. This is the part of the virus that gets stuck in the human body after infection. And then the vaccines, largely Pfizer, Moderna, and Janssen, superload the body with spike protein. So spike protein, we've learned, is not readily cleared from the human body, and the body forms a reaction to it called an antibody. So Dr. Drew, you can measure your own antibodies against the spike protein as an indirect proxy of what your burden has been in your system. It's widely available through Quest and LabCorp. People can even order it themselves. I found a website called healthlabs.com in the United States. You can type in spike antibody, order it yourself, send it to whatever lab you want to. The requisition's right there, and get your test.
Interesting. And Susan wants hers. And then talk a little bit about the coagulation issues because that was when we first talked. We were in British Columbia, and you laid out your theories about that. I was fascinated. That was the first time I heard it, and I feel like that has been, if not entirely completely confirmed, largely confirmed.
I spent time today with a patient with a pulmonary embolism. That's a blood clot to the lungs. In my estimation, and I've directly examined now thousands of patients through the pandemic, it's my estimation that the risk of blood clots after the infection is equal to the risk of blood clots after the vaccines. And the people who've had more infections and more vaccines are at the highest risk. The spike protein causes blood clots, and it's physically found in the blood clots. So virtually all of us, 97% of us, have had COVID now. I have 3 times. I think all of us are predisposed to blood clots. And when I do genetic analysis in my patients, at least half have some genetic predisposition towards blood clotting. So I'm worried about everyone and the risk of blood clots.
So that would be like a lupus anticoagulant or a protein C or protein S abnormality, that sort of thing. Because I noticed with COVID, I had a patient with lupus anticoagulant, and he died very quickly. It was one of the only deaths in my patient population, and it was wild.
Oh, boy. Well, yeah, this is what we know. So look at me. I'm Caucasian, Irish, factor V Leiden. Right, so I fit the profile. So there's factor V Leiden, protein C and S abnormalities, prothrombin variant 2021A. There's fibrinogen variants, and of course the lupus anticoagulant, which is an induced autoimmune factor. And we found that we have different anticoagulation strategies. But I'll tell you one thing I've learned: the lupus anticoagulant, and hematologists agree, they need warfarin. Nothing else seems to work. I know. In that scenario.
I'm sure of it. I'm sure of it. And we didn't know. I wasn't taking care of him in the hospital. He was down in San Diego, but he was a long-term patient of mine. And for all we know, I mean, he might have had microvascular clotting throughout his lung, or he might even had some who knows what, but he definitely should have been on warfarin or even possibly multiple anticoagulants. But yeah, Jordan Vaughn mentioned that to me too. I don't know if you talked to Jordan at all, but he's come to he's right in that same zone with you as it pertains to coagulation abnormalities.
Jordan was on my team just in the U.S. Senate a few weeks ago on May 21st. I sat right next to him. He's a very bright internist. He runs the largest vaccine blood clot center in the United States. And he uses, like I do, he uses a ton of blood thinners, which kind of hold the blood clot, at bay. But we've learned that we need to dissolve the blood clot, and there we use enzymes. The lead ones are nattokinase and bromelain. And recently the Japanese have reported that they add sereptase, lumbrokinase. These are oral forms of proteolytic, thrombolytic enzymes. And of course, the very big blood clots are so well organized, they have to be removed by surgery.
And you can use the spike support that you've developed. Now do we have a high dose alternative now too?
Yeah, so the original was spike support, and now we've advanced to ultimate spike detox, which combines nattokinase, bromelain, and curcumin, as well as several minor ingredients in a high dose. So on the package label, 2 capsules twice a day delivers 8,000 units of nattokinase. And then, commonly in my practice, I advanced to 4 capsules twice a day. We're talking Wellness Company Ultimate Spike Detox, and that delivers 16,000 fibrinolytic units. That is quite high from our original publications a few years ago when we were at 4,000, for the day. Recently the Chinese have published a study out of the box. They're using 10,000 units. We believe the safety limit on natto is about 80,000 units a day. So we're still well below.
So let's do a little MAHA talk for a second. And by the way, before I leave the stroke thing, I also noticed strokes in young people post-vax, and that should be alarming everybody. When I first started seeing it, I was like, you gotta be kidding me. And it's just sort of, and the kids are being hospitalized. Oh, well, but it's just stroke's one of those things. You on birth control pill? No, well, who knows? Who knows? Oh my God, I'd never seen a stroke in a 30-year-old. Now I've seen quite a few.
Yeah. Yeah, I agree. We're seeing just, cardiac arrest, myocarditis in young people. That happened actually before the pandemic very rarely. Myocarditis is about 90% in boys, 10% in girls, but it extends through the range. Even former Tampa Bay Bucks coach Bruce Arians was hospitalized for vaccine myocarditis in his 70s. Well, a 1 month hospitalization. I have a young man. He's a professional athlete right now. He took the shots in 2021. He's in the hospital now with myocarditis. It's periodically he has to be hospitalized. This is not going away. And of course, the risk for stroke has occurred because of hypertensive intracranial hemorrhage. That happened to Barbara Orendello. She was at the Senate hearing. And now recently, the Japanese have reported the spike protein is found in the blood vessels in the brain where it's burst at sites of weakness.
Is there any of these, there's sort of a slow growing international consensus to your point of view, let's call it. Is that coalescing in some way? I mean, everyone's getting silenced in their respective countries. Is there any sort of unification underway?
Yeah, the safety concerns are growing. The medical community has kind of silently stopped taking the vaccines. They're not yet having grand rounds on this topic. Sadly, they're not taking vaccine or COVID histories in people being admitted with myocarditis or blood clots. And they're really missing the exposure. Right. Dr. Drew, this is very similar to, let's say, 1950. If you and I were to walk into Harvard at 1950 and say, listen, we're concerned smoking causes lung cancer. If we just said that, they'd say, listen, guys, don't worry, we got this. It's safe. Smoking's fine. We smoke. Our patients smoke. Our nurses smoke. Everything's fine. And if we were the canary,
very familiar,
right? And it took 1964, Luther Terry, Surgeon General report on smoking. He calls the chiefs of medicine to Washington. You should see the look on their face in this film. He said, guys, I got bad news for you. Smoking causes lung cancer. So we're going to have that type. We live long enough. We're going to have that type of capitulation where people are going to learn. Oh my gosh, we promoted these vaccines and look what happened.
I want to talk about MAHA and RFK in just 1 second, but I want to present a quick case to you. Patient comes in with nausea and vomiting. EKG looks normal, but enzymes are up, like high. Then after a day, the EKG gets a little weird. An echo shows a ejection fraction of 15% and global left ventricular kind of focally, but more global dysfunction. Patient leaves AMA because everyone seemed to be not understanding what was going on. Follows up with a cardiologist 10 days later, has a follow-up echo, normal wall motion, 60% ejection fraction. And that cardiologist even went, I don't know. But nobody takes a vaccine history or talks about COVID or anything. It's wild to me.
Yeah, that's a classic case of what's called Takotsubo cardiomyopathy or broken heart syndrome. So it usually leads with some GI symptoms. There's this dramatic change on EKGs and then global left ventricular dysfunction and prompt recovery. And what we've learned is some people have polymorphisms in beta adrenergic receptors. It's the outflow of catecholamines, epinephrine, norepinephrine, dopamine. The heart responds poorly to it. Yeah, it can be triggered by COVID or the vaccines, but you know what? It existed long before the pandemic.
Fair enough.
Okay, we have no idea what you guys just talked about.
It's enough. Don't worry about it. We're just talking about a case of myocarditis.
I tried to follow.
But Susan, it's called broken heart syndrome. It can happen.
Yeah,
I got that part.
Yeah, it was debated whether it even exists for a long time, but it does exist.
Wait, because you're sad?
You're shocked. You're really grief-stricken, shocked by something.
Oh.
That's it. So you want to get the history. It's more common in women than men, and you'd want to get the history. What was it? Was there some type of shock? Sometimes it can just be some food poisoning, it's GI that trips it off. But there is a characteristic GI and then cardiac presentation.
Interesting. I didn't know the GI part. So MAHA vaccines, there's a lot of get rid of mRNAs, period. There's a whole MAHA world that will accept nothing other than total removal of the platforms, and particularly the COVID platform. Where are you with all that stuff going on?
Well, in many ways, the train has already left the station. In a paper by Lalani, the British Medical Journal, we've invested globally billions upon billions of dollars in messenger RNA. Most chiefs of medicine around the the world. They think messenger RNA is going to be the solution to future, human disease. There's a giant belief system. It's messenger RNA for, vaccines for cancer, not just vaccines, but, messenger RNA treatment. So messenger RNA can produce any protein that we want to produce. Can you imagine that? It's like a molecular biology playground. The challenge would be to develop messenger RNA to maybe replace deficient proteins, create interfering proteins that are benign. And we need to understand with messenger RNA how to turn it on in the body and how to turn it off.
So I think I hear you saying that a reasonable or cautious, like with every medication, which are always dangerous, that we don't throw the baby out with the bathwater. Is that my position? I'll tell you mine is, I don't like doctors being restricted from having access to anything that they actually feel could help their patient. The problem is we've gone through this period where doctors weren't paying attention. They weren't thinking in terms of risk reward. And we use dangerous stuff all the time when the risk warrants it. And to have an mRNA platform, or even CRISPR is a whole different thing because we don't know the downstream effects of all that. But I just want us to have back to the days when companies produced products that doctors then used if we thought it was in the best interest of our patients. We were not mandated to use things. We didn't have a political position when we used things. We weren't socially sanctioned for not or doing, or it's just we did what was best for our patient. So that's kind of where I come from the mRNA. So I worry that there's so much energy or pressure on RFK Jr. that they're going to throw the baby out with the bathwater.
I don't think so. The industry is so large, Dr. Drew. Like giving an example, and the data well, that there is a vaccine for melanoma that's being tested as part of combination chemotherapy, in conjunction with Keytruda. Can you imagine a vaccine that creates an antibody, and the antibody specifically targets a tumor antigen? That's not another antigen in the other cell type. It could be a breakthrough. But I finished with a patient today. He is in research. We're using a lab in Germany. We have detectable Pfizer messenger RNA in his body now, 3.2 years after the shots. For sure. For sure. So people who took these shots, they've got it. They've got it at least long term now. And I've testified in the House last year, and I said, listen, I think we got 5 to 15 years, of concern here. This is very long-acting genetic material. And I think we should assume that all messenger RNA coming forward is going to be very long-acting in the body, and we need to be prepared for it. So I've said this, the platform should not be in clinical use in people right now, but in anybody taking messenger RNA, they should be in a research protocol.
And carefully selected. And when the risk is warranting it, not giving everybody in the world. That's just the fact that we did that. It's just, I can only laugh. It's the wildest thing that we did that. It just shows you how horrible things can go when you centralize authority with medicine. And I'm also worried about the cancer risks and things. I've been watching Patrick Soon-Shiong talk about natural killer cells and his very grave concern about that. For me, I just take resveratrol, try to improve I ask my family to do the same thing, to try to do the best we can for our natural killer function. I'm not sure his whole thing is a great idea. I don't know, but he certainly raised an awareness that may be one of the mechanisms of the increase in cancer that we think we're seeing.
Remember, you can orient your diet to be anti-cancer, Dr. Drew. You and Susan may want to, consider this. So very good data for curcumin and turmeric, for instance. Very good data for black sativa, cruciferous vegetables. I did a whole show on the McCullough report. I invited a person on. You may want to have him on a show. His name is Michael Gaeta, Gaeta. He runs the Gaeta Institute in Boulder. Probably the most, knowledgeable and great communicator on these natural topics. And, according to Gaeta, you can orient your diet and your supplements to be globally anti-cancer, just like you could to be, anti-atherosclerotic.
Or anti-diabetic, or testosterone or estrogen. But I take turmeric with curcumin. I do that. So I am persuaded there's a lot going on with that supplement. It's kind of weirdly the golden age of supplements. Things that you and I were not trained to do suddenly have really well-described mechanisms where they look pretty darn good.
Right. The average Indian in the Indian subcontinent consumes about 2,000 milligrams of turmeric or curcumin per day. You probably get it. And they do have population weight lower rates of cancer.
And there are things to be concerned with in terms of how these things are absorbed, and there are cofactors you can improve it. Anyway, bigger topic. But listen, I'm going to let you go. I appreciate you being here so very much. It's always a pleasure to talk to you. I guess we'll all be on the phone on Friday, maybe, to talk about new projects.
I wonder what Peter thinks about AI in medicine. How it can help.
Okay. We're gonna talk to Joe Allen in a second about AI and some of the
transhumanism
excesses and concerns and whatnot. But and let me just go ahead. Go right ahead.
Let me just say quickly, if AI could help assemble medical records and help present disparate sources of medical information, it would be great. But I want the AI to work for me. I don't want to be the data gatherer and then try to give it to AI to give me an answer. I think it has to be set up to the AI truly is artificial assistance is what it should be.
Right, and not mandates, which if you love your electronic medical record, it's loaded with stuff that they're telling us to do. This is more on high BS that same thing that brought us COVID mandates. All right, thank you so much, Peter. We appreciate it very much. See you soon. And again, do follow him on X, P_McCullough MD, and also petermccullough.com, petermcculloughmd.com.